Regarding the thoracolumbar spine, a Dennis classification is important. Dennis classified thoracolumbar injuries into three different columns. Anterior column is the one which is between the anterior 1.5 of the vertebral body. The second column is from the posterior half of the vertebral body, and the third column is which consists of pedicle facet joint spinous processes, postural ligament complex, intraspinous ligament flavum. There is a classification called Mageral classification, which consists of A is anterior compression or a burst fracture, B is a flexion distraction injury, C is a rotation injury. Regarding any patient which comes, the compression fracture is when there is a failure of anterior vertebral body without distribution of posterior structures. X-ray would be feasible, which shows anterior wedging, and usually the loss is less than 30%. The causes are osteoporosis, for which MRI can help in evaluating its acute or chronic. Metastatic lesion if above T5. A younger patient with no history of fall because of infection or multiple myeloma. Treatment is orthosis or kyphoplasty if patient is symptomatic for after 6 weeks of conservative measurements. Kyphoplasty is expansion balloon which is inserted to the needle and filled with cement. This is indicated for patient with painful bone metastasis. In this, high viscosity cement is used under low pressure to avoid embolization via Bateson plexus. Vertebroplasty is an approach which no balloon is used, and there is low viscosity and high pressure utilized. Anterior stabilization is indicated if more than 50% compression or more than 30 degrees of kyphosis. A burst fracture is a fracture which is anterior middle column are involved. These are anterior column there is a chance that to have a ligamentous injury. This can be identified by the widening of the interpedicular distance along with loss of height. MRI is indicated to check the posterior longitudinal structures. Management can be conservative in the form of TLSO if the patient is mechanically stable and their posterior longitudinal complex is intact. Decompression stabilization if neurological deficit is there. In progressive kyphosis is suspected, especially in thoracolumbar fixation is advisable. Course meta-analysis showed that operative management of thoracolumbar burst fractures without neurological deficit may improve the residual kyphosis, but does not improve pain or function at 4 years. Bailey et al. And Urquhart in Journal of Neurosurgery showed no difference in functional outcome with or without TLSO brace for burst fracture with no neurological deficit. Mumford et al. In 1993 and Dye et al. In 2001 showed that there is no difference in canal remodeling which gets completed, with most of the bony retropulsion or intraspinal fragments resolved by 1 year.